meeting. It's currently 2:35. We are we needed to make some changes to the schedule. We're putting a pin in compounding conversation at this time, as we have some other time restricted or schedule restricted items that we need to address now. And then after we complete those, if we continue to have time at the end of the day, then we will resume compounding discussions at that time. Now we would like to recognize an outgoing board member, Cindy Lipperman. Yeah. Okay, hey, you can save 10 minutes.
You could do more compounding.
The board would like to recognize the service of certified Oregon pharmacy technician member Cindy Vipperman. Cindy was one of the first 2 pharmacy technician members appointed to the Oregon board. Her term began on February 17th, 2016. We are grateful for her passionate voice for the public health and safety of Oregonians over these past 8 years. Cindy's career includes being a member of the healthcare team for over 21 years at Fred Meyer in the Dalles as the lead technician and inventory control manager. In 2019, she shifted to working in health systems pharmacy at St. Charles Healthcare in Bend. Significant accomplishments and activities during Cindy's tenure with the board include participating in the board's strategic planning processes and meetings, navigating the entire COVID-19 public health emergency, implementing legislative directives and OARs to improve equity of pharmacy services such as limited English proficiency labeling, prescription readers for the visually impaired, cultural competency and pain management continuing education requirements, remote dispensing site pharmacies, pharmacy prescription lockers, pharmacy prescription kiosks, public health. Wow, sometimes it's so long. Public health pharmacy formulary advisory committee, protocol and formulary compendium. She also participated in a 2021 pharmacy technician rack, participated in 2 executive director recruitments. Cindy also became the first pharmacy technician member to serve as vice president of the Oregon Board of Pharmacy, and then in 2019, the president of the board. Cindy has contributed significantly to the board's policy and strategic discussions over the past 8 years and has been a staunch advocate for patient safety. Her contributions to board decisions and rulemaking, utilizing her experience as a certified Oregon pharmacy technician, has been invaluable and has served to advance public health, safety, and welfare. Cindy, your presence on the board will be missed, and we wish you all the best as you pursue new adventures. On behalf of the board and agency staff, thank you for your dedicated service to the board and to the citizens of Oregon. You asked for a couple of moments.
The one thing that is, the one thing that's different, okay, right now is that this, opportunity has made me a better technician by being on this board. I wouldn't be here if it wasn't, for the, opportunities that the governor gave me, to be here. The staff has all been invaluable. You are the people, the heroes of this agency. You're the ones who go out and you investigate and you bring it back, and then we decide what we're going to do with all the information. I think I got a list. Hang on. I would like to make sure that you all know that I will never stop advocating for patient safety. I would never stop advocating for technicians to be involved in their license opportunities and growth. And that's what I'm going to do with my future. We have been through a pandemic together. Some of us have gone through 3 executive directors, and the changes that those bring, they are sometimes good. We've been through cancer patients. We've been through people passing away in our families, and we are all a family. We may not agree on everything. We do agree that we are all family. We all make a difference in what we do here on the board. I'll never forget this. This has been a highlight of my life, and I thank you all for that. So thank you.
You have a plaque for you, and if Executive Director Fox and you walk up with me, then we'll keep a picture
that would be great.
with staff member Melvin.
Oh my gosh. Oh my gosh.
Oh, don't look at the lights. Yeah.
Yeah.
And watch your.
Okay. Oh, and a card. Okay, wait, you're gonna be in it too, right? Oh, wait, hang on, I don't want the card.
That's okay.
Yes,
Okay.
yes.
1, 2, 3. 1, 2, 3. One more. 1, 2, 3. Thank you.
Thank you, and you'll send that to me, right?
I can do that.
Thank you so much. Thank you so much. And you spelled my name right. You don't even know how nice that is. You're the better. Yeah. That's awesome. Thank you so much. For the end of people.
Board Member Doyle speaking again. We would also like to announce that Board Vice President Chin and Board Member Joyce are scheduled to be confirmed by the Senate for their reappointment. My understanding is that part 1 of 2, if you will, has occurred, and the part 2 should happen, or the actual confirmation should happen next week at some time. The governor has appointed Darely DePaul, who will replace Board Member Vipperman, and is also scheduled to be confirmed next week. We anticipate Darely would join us for the April board meeting. We would like to share that the board has 2 pharmacist member positions available for appointment, and interested parties should apply by February 12th. That's this upcoming Monday. And we'll find the link to the application and relevant resources on our quote unquote opportunities page on our website. We would also like to mention that the Public Health and Pharmacy Formulary Advisory Committee has the following member opportunities available for appointment or reappointment. That is 2 pharmacist member positions, 1 physician member position, 1 advanced practice registered nurse member position. At this point, we'll redirect our attention to safe pharmacy practices. If you will recall, I'll just say approximately 2 meetings ago, at the end of the last day, I held a conversation about wanting the importance for us as a board to revisit safe pharmacy practices. And there was board consensus that we needed to move in that direction. Staff member Davis, with a little bit of my help, has created this presentation, which had been scheduled to show you at our last meeting, but had to be deferred because of time limitations. And so staff member Davis will be leading us in a sort of a recountance of where we stand with safe pharmacy practices in Oregon. And we'll be asking for your directional input at the end of the presentation. Staff Member Davis.
Thank you. Good afternoon, board members, members of the public. As requested by President Doyle, I've prepared this presentation to facilitate a renewed discussion on the crucial issue of safe pharmacy practice conditions. Following the presentation, President Doyle will invite board members to share your thoughts and suggestions. As I'm reviewing the presentation, President Doyle requests that you please take notes about what you think the board could be doing to increase safe pharmacy practices and patient safety. Think about things like, would you want to redo the survey that, briefly mentioned, amend rules? So just what, or other more fantastic ideas. So for now, let's just get started. First, let's look at the history of the Safe Pharmacy Practice Conditions Work Group. There were 9 work group members and 2 board members on the work group. Representatives included both technicians and pharmacists from a broad variety of practice areas. We had community pharmacy chains, community independent, health systems, long-term care, and specialty pharmacy. The first project for the work group was to determine if a survey should be sent and develop the questions for the surveys. The board has historically sent practice condition surveys in 2011, 2013, 2016, and then again in 2022. The 2022 survey was different than previous surveys based on recommendations of the work group. I'll not be reviewing the survey results of the board as they were presented to the board in April 2022 and can be found in the board meeting minutes for that meeting. But almost 18,000 licensees received the survey, and responses were received from almost 2,000 licensees. Next, the work group participated in a fishbone exercise. This is also known as a Ishikawa diagram or cause and effect diagram. It's a visual tool that's used to identify and analyze the potential causes of a problem. It helps to break down a complex problem into smaller, more manageable components. Staff created a list of possible policy solutions that were then discussed by the work group, and the work group ranked those policy priorities based on perceived impact to increasing safe pharmacy practices. The work group also reviewed some possible rule language options. In February of 2022, 2 years ago, I can't believe it's already been 2 years, the board issued a safe pharmacy practice statement for licensees, and that can be found in the position statements on the board's website. As the work group concluded its work, the board began to contemplate rules in August of 2022 that aligned with the policies that were prioritized by the work group that would have the greatest impact on pharmacy workplace conditions and patient safety. The board adopted rules related to safe pharmacy practice conditions for outlets and pharmacists in February of 2023, so a year ago, and technicians in August of 2023 that become effective on 3/1/2024. Next slide. This slide shows that fishbone exercise that was completed by the work group. The work group identified equipment and technology, personnel, environment, and regulatory conditions that compromise patient safety and staff's ability to practice pharmacy in the best interest of each patient. The fishbone diagram shown here does not assign weights to individual factors. So for instance, quotas or metrics that's under the environment category is not explicitly identified as having a greater or lesser influence than on the problem than staffing and workflow factors, not weighted in priority, just listed. Next slide. Based on the identified equipment, technology, personnel, environment, and regulatory conditions that could compromise patient safety and staff's ability to practice pharmacy in the best interest of their patients, agency staff developed a list of possible policies that could be addressed in rule to mitigate the concerns of the work group. The work group members ranked the policy topics based on how likely the policy was to improve the workload and or safety or safe pharmacy practice conditions. There was a 5-point scale with 5 being extremely likely and 1 being extremely unlikely. Based on the impact score, policy topics were ranked. There were many ties, so you see that in the rank list on the slide. Like there's no number 3 in the rank. It goes 1, 2, 2, and then 4 because there was a tie for that second and third spot. Policy options with a star indicate that rules have been rules related to that policy topic have been contemplated by the board. The most impactful policy topic selected by the work group was to require e-prescribing. The work group expressed that e-prescribing could help the pharmacist workload by decreasing translation errors, reducing fraudulent activity, reducing the number of incomplete prescriptions, increasing the speed of filling prescriptions, and increasing pharmacy efficiency, which would then allow more time for patient care. They did express some concerns around implementation and the processes if the technology were to fail, like you have a power failure or SureScripts goes down, because we've had that happen in our worlds. Agency staff further investigated this policy topic and were unable to locate a state that has implemented rules mandating e-prescribing without a corresponding piece of legislation. The board can regulate our licensees, but it's very difficult to regulate any other type of licensee. So the board could contemplate rules to require pharmacists to use e-prescribing, but that would not have the effect that the work group was discussing, as the pool of pharmacist prescribers is very small compared to prescribers that are regulated by other boards. There are a few local examples of this sort of legislation. California 2018 Assembly Bill 2789 required that both prescribers and pharmacists have the ability to e-prescribe by January 1st, 2022. And prescribers were required to e-prescribe all prescriptions. There were some exceptions mentioned in the bill, but they did not include waivers. Nevada in 2019, Assembly Bill 310 mandated that all controlled substance prescriptions be electronically prescribed by January 1, 2021. And Washington in 2019, Senate Bill 5380 mandated that controlled substances also be prescribed electronically. So there are some bills. There's also some federal legislation, Medicare plans starting in January 1, 2023. And I don't think that got delayed again. I think it actually happened. That electronically prescribed prescriptions were required for Part D and Medicare Advantage RX plans. So they're seeing some from other states and on a national level, but Oregon has not had legislation to date. Next slide. Tied for the second spot with pharmacist autonomy were lunches and breaks. These were all ranked as high as the policy topics that could affect change. The work group provided comments such as that it appears that pharmacies aren't providing uninterrupted breaks, meal breaks, don't address the backlog of work in understaffed pharmacies, and the rule doesn't and rules don't address upset patients waiting for prescriptions. Breaks, they wanted to increase breaks can increase performance and safety, and the rules should specify the time increments. Otherwise, it could be left up for interpretation. In addition, they wanted breaks to provide staff with more focus and could increase patient satisfaction. Overworked and stressed personnel are a liability. And if a pharmacist must close for breaks, it could limit patient access to care. So you can see, like, there was a lot of differing opinions on how much to regulate, if to regulate. So when the board contemplated amending these rules in 2022, 2023, it built upon previous rules we already had in place and added to the grounds for discipline to make it clear that failing to provide a working environment that protects the health, safety, and welfare of a patient, as required in 855-041-1010, includes appropriate opportunities for uninterrupted rest periods and meal breaks, and that is now grounds for discipline in our state. Other states have more specific rules about the length of a break, the maximum shift lengths, and I'll kind of go over those in a minute. But at this point, we've seen that many major chain pharmacies have a preset time that the pharmacy is now closed for lunch, and that's been a change in practice over the past couple of years. Tied for the second spot with lunches and breaks was pharmacist autonomy. Again, highly ranked by the committee or by the work group. The work group provided comments on this policy topic, including that currently pharmacists were disempowered from impacting their work environment, which led to a systematic decline of work conditions, safety, and legal compliance. They wanted to see empowering pharmacists to determine staffing and pushing back against staffing type of metrics so that they can have safe and legally compliant operations. So similar to lunches and breaks, the board took a two-pronged approach in addressing pharmacist autonomy and role. First, it required the outlet to provide a working environment that protects the health, safety, and welfare of a patient, which includes but is not limited to ensuring there's sufficient staff to provide services in a safe manner. The rule also requires the outlet to abide by the pharmacist on duty's decision to temporarily shut down a service or services, and they must respond substantively to a pharmacist who has identified staffing concerns. The second prong was to make it grounds for discipline. So if the outlet overrode or interfered with the pharmacist on duty's control of all aspects of the practice of pharmacy, it could be grounds for discipline. Next slide. Coming in at 4 was the policy topic of pharmacist counseling. And during the fishbone exercise, the work group members asked the staff to consider developing counseling rules that are the same for mail order and in-person pharmacies. Consider adopting rules that allow the pharmacist to determine what needs counseling and allowing the pharmacist to override counseling generated by pharmacy software. During the policy topic discussion, members wanted to ensure counseling rules were clear concerning the utilization of alternative methods of counseling versus oral, and use technology for written documents. The rules that were adopted, so this is a presentation I created in December. You did actually adopt the new counseling rules in December. The rules that were adopted by the board earlier in December address these concerns. We have the new definition of counseling that contemplates counseling other than oral counseling and permits the use of technology for written documents so long as the format is accessible by the patient. Tied for 5th with discretionary clinical services was pharmacy access. This policy topic was not identified by the work group during the fishbone exercise. Agency staff added this topic to the list of possible policy topics for the work group to consider per direction of the board at the June 2022 board meeting. At the July meeting of the work groups discussed this policy topic, and consensus was that although they liked the concept, they had concerns about diversion, supervision, and security issues with permitting non-pharmacist personnel to be in the pharmacy without a pharmacist. At the August 2022 board meeting, the board discussed pharmacy access by technicians when a pharmacist is not present, and the requirements of a pharmacist to supervise, direct, and control technicians, and that specific requirements would be needed to be in place to permit access. The board agreed that non-licensed personnel should not have access to a pharmacy when a pharmacist is not present, and discussed requiring dual licensure, so a retail pharmacy license and a remote dispensing site pharmacy license for a retail pharmacy that would allow technician access without a pharmacist present. The board provided direction at the time to table that discussion, since pharmacies could obtain an RDSP registration to permit technicians to physically enter the pharmacy when a pharmacist was not physically present. The next month, the work group discussed this topic again, and while there was still not consensus on the work group and the topic, they did like the idea as it would possibly allow some clerical tasks and monthly maintenance or inventory to be completed without the pressure of patients in the pharmacy. But other members continued to express concern that the pharmacist would still be liable for the drugs and the actions of non-pharmacist licensed persons in the pharmacy when the pharmacist wasn't present. The remote dispensing site pharmacy was discussed as a possible solution, but work group members recognized the cost to implement the technology may be prohibitive. The tied for 5th with pharmacy access was also discretionary clinical services. So shown on the slide are the same rules you saw earlier related to pharmacist autonomy, which was tied for 2nd in the policy topic options. Language about discretionary clinical services is included in OAR 855-041-1010. The outlet must abide by the pharmacist on duty's decision to temporarily shut down a service or services. And then also in OAR 855-041-1170, the outlet can be disciplined for failing to abide by the pharmacist on duty's decision to shut down services. Next slide. Coming in at 7, the work group requested clarity and rule on the role of non-licensed pharmacy personnel. The board has addressed this issue in the rewrite of the pharmacist rules in Division 115. The pharmacist is responsible for non-licensed pharmacy personnel under their supervision. They must not permit and they must ensure that these personnel do not practice or assist in the practice of pharmacy. Next slide. Coming in at 8 and tied with workload, staffing in technology and a staffing report form were technician tasks. The work group wanted the ability for techs to do more and not be limited by a list of permitted tasks. The work group reviewed the language that the board adopted in August 2023 and indicated that they liked that it matched the statutes and was simplified. Fine. Instead of limiting what a technician can do using a list of permitted tasks, the board has sent through rulemaking and adopted now a list of prohibited practices. And this, just so you know, the language on this was prior to the December board meeting, so it's not the final language that got adopted. Next, the work group discussed these items after the policy topic survey results were released. But these items did not have a strong recommendation by the work group to further discuss or put effort into regulations related to them. The first one being workload, staffing, and technology. The topic was about requiring the outlet to provide reasonable and accurate staffing expectations. The outlet, in coordination with the PIC, would have to evaluate the pharmacy environment, and they must use available data to determine if current staffing levels and technology is sufficient to prevent clinical delays in patient care. The staffing report form was a proposal based on an Oklahoma rule. The outlet would have to provide adequate staffing. In the event of inadequate staffing, a staffing report must be completed. It must be provided to the PIC and their supervisor and kept on file for the board for inspection. If the pharmacist deems necessary, they could report directly to the board. Quotas, this proposal was based on a California law to eliminate the use of quotas in the pharmacy. A staffing plan was based on an Oklahoma rule and a Virginia law, again requiring the pharmacist in charge to develop a staffing plan that establishes the appropriate number of interns and technicians that are on duty. It must ensure that those people on duty can be satisfactorily supervised by the pharmacist. Touch points was related to providing autonomy to the pharmacist on duty, and we kind of captured that already with the autonomy rules, so it kind of got looped in there. A technician ratio, other states use them. If the pharmacist determined if a ratio was needed, then the drug outlet must comply. It's kind of the premise of that idea. And then work areas, the proposal was based on a Mississippi rule that the outlet had to provide the space and layout to accommodate workflow in an organized fashion. So since the board's previous work on the topic of safe pharmacy practice conditions, this topic has continued to make news headlines. And due to pharmacy closures, we've had national walkouts. There's been increased calls by pharmacy with people practicing in a pharmacy for safe practice conditions that promote patient safety. Next, I'm going to just cover what a few states' efforts have done to regulate workplace conditions. So we've done some work, so have some other states. We like to see what other people are doing just to get ideas. So in Virginia, since 1999, the PIC has been responsible for all aspects of the pharmacy, and any decisions overriding their control can be grounds for disciplinary action on the outlet. Since 2016, a pharmacist cannot work more than 12 hours in a row and must be given a 6-hour break between shifts. In Illinois, starting in 2020, pharmacy licensees cannot be required to work more than 12 continuous hours per day, and they must be given breaks. After 6 continuous hours or longer per day, they have to get one 30-minute uninterrupted meal break and one 15-minute meal break. There's other break cutoffs in their rule. They updated it January 1st of 2024 to include a provision that would allow technicians and interns and other support staff to sell prescriptions that have received final verification by the pharmacist, even when a pharmacist is not present. It does require these pharmacies to have audio and visual and video technology to connect patients to a pharmacist for counseling. And if the pharmacy doesn't have this technology, then they have to get a phone number from the patient where the pharmacist can call and talk to the patient to provide the counseling. It also requires the pharmacies to provide training to all staff on this whole system. The next slide, Missouri has passed a number of regulations. They amended their rules in 2022 to prohibit pharmacies from introducing any policies, procedures, systems, or practices that jeopardize, inhibit, or threaten patient safety or the safe provision of pharmacy services. It included enforcing any metrics, quotas, or performance or target goals that could endanger patient care. In Oklahoma, starting in September of 2023, pharmacies in Oklahoma are responsible for ensuring adequate staffing to safely fill prescriptions. Pharmacists must complete staffing reports when they feel staffing is inadequate or excessive workload exists. The pharmacies must review the reports, address the issues, and document corrective actions. and employees cannot be disciplined for filing reports or reporting violations. The board has published their own inadequate staffing report form on their website, and it's now included in the regulations as a standard adopted by rule in 2023. California has passed a number of laws in recent years. Almost everything in California goes to the legislature rather than rulemaking. So I have three laws just to quickly discuss. 2018 Senate Bill 1442, also known as the No Pharmacist Left Alone law. It aimed to protect public health by ensuring that licensed pharmacists have adequate support and are not left alone for long periods of time while working or while practicing in the pharmacy. The second one is 2021 Senate Bill 362. This is the no quotas rule. The law aimed to protect public health by prohibiting chain community pharmacies from imposing quotas on pharmacists and pharmacy technicians. And then the last one is the most recent one, the 2023 Assembly Bill 1286, also known as the Stop Dangerous Pharmacies Act. It was just signed into law by the governor in October. And it aims to enhance patient safety in California by empowering pharmacists, promoting better staffing practices, expanding technician roles, increasing transparency, strengthening enforcement, and preventing unprofessional conduct. One of the things of this rule that's unique that we haven't seen in any other state is a mandatory anonymous reporting of medication errors to something like what you would know as a patient safety organization. But it now is required by state law for pharmacists to report certain levels of errors to this data bank that then uses the data to help inform future decisions about patient safety and things that can be done in pharmacies. And finally, the Ohio board recently filed a set of rules. It's shown on the slide. It looks like it went to November and December board meeting. They have a multi-step process, so things are a little further along. The rules at the top are now sitting with their joint committee on agency rule review, and will be reviewed in later next week. The rules include requirements for pharmacies to develop a process to address staffing concerns, provide for mandatory rest breaks for pharmacy personnel, ban the use of quotas, require pharmacies to dispense medications within a certain time frame to avoid delays that endanger patient health. I'll just briefly step on these. I think these are probably some of the most sweeping regulations we've seen, and will be interesting to see if they make it through the whole process. But for the first one in DAT 5-02, this is just their minimum standards for the operation of an outpatient pharmacy. Pharmacies must have adequate personnel resources and security to support their pharmacist in fulfilling professional duties. And 02.1, the ancillary services. This prohibits using quotas for services like immunizations and medication therapy management. 02.2, outpatient pharmacies in Ohio cannot require pharmacists to work more than 12 hours, with exceptions for documented emergencies and voluntary extensions. They must be given a 30-minute break after 6 hours of work. And 02.3, they must use a board developed form to report staffing concerns, which must be kept on file for inspection. The pharmacies must respond to the concerns and take corrective action. It must be documented for 3 years and communicate their actions to the reporting pharmacist. It also prohibits retaliation against pharmacists, and this is kind of a newer thing we're seeing in a lot of states, is anti-retaliation language. 02.4, significant delays in the provision of pharmacy services. So Ohio pharmacies must dispense prescriptions within 72 hours unless there's a documented shortage, clarification needed, insurance delay, compounded drug, or suspicion about the prescription. Delays beyond 72 hours are violations and subject to disciplinary action. 02.5 is about access points. It empowers their pharmacists to manage their workload by allowing them to limit ancillary service and shut down access points. And then towards the bottom are rules that are still kind of not as far along in the process, but it's kind of relating to what we just saw in California. Pharmacies must have quality assurance programs to analyze and document dispensing errors. Upon discovering an error, they must inform the patient, caregiver, and the prescriber, except for certain minor errors that are outlined in the regulations. And so they're also updating all their duty to report rules, you can see, to require the reporting of these quality incidents. So to recap, I've gone over the previous work completed by the board regarding safe pharmacy practice conditions. We've reviewed the top ranked policy topics that were identified by the work group and some current and pending regulations by other states. The board has a number of options to consider as it moves forward in addressing the issues raised by the work group. The board will need to determine where it wants to go from here. Do board members want to see the rules amended further to address issues identified by the work group that have not already been addressed? Do you want to reconduct the survey? It was historically completed every 2 to 3 years. We're at 2 years since the last survey. And what other ideas do you have? And I'm going to hand the floor back to President Doyle for board discussion.
Member Doyle, thank you for collating this information and making the presentation to us. So what I'm asking, based on this information, and staff member Davis encapsulated the question, where do you see that we as a board can make an impact with starting a path towards potentially resolving issues related to some things that are in the press and or things that we have seen as a board through our cases, and some issues that that we might not have rule around, and do those things need to be addressed? So we had last started off with board member Hemmons, and so now we'll start with broad recommendations of where to go from here with board member Beeman.
Thank you, Board Member Beeman. Given that it's been 2 years, I do think a new survey would be helpful. A lot of changes have happened, like in the world, as well as we've had a lot of new rules and rule changes that it would be helpful to see how those are impacting pharmacy in reality, not in the theoretical. Broadly, staff member Davis made a statement that, not quoting word for word, but along the lines of California almost always goes through legislature and not rulemaking. And that's a very scary comment for me. I myself don't wish that for Oregon pharmacy. Legislature cannot move and adapt and pivot the way that a board of pharmacy can in terms of rule changes as things come up and change and evolve. And pharmacy is in an era of evolving more quickly than a lot of other changes could happen. So I think we need to be really mindful of that as we move forward with things, and listening to stakeholders and such. I do have a question regarding, and I could be wrong in thinking back, but I believe at one point the technician pharmacy access was told to us that it would potentially go against statute because of the direct supervision and control statement within the statute. So I think reevaluating that and seeing where that lies in allowability, can I make up words now? Would be interesting to re-entertain and reassess. Other notes, but they're a lot more specific. And then with regards to like outlets providing adequate staffing and creating rules around that, I think that's very hard in an environment where we don't have applicants. Both not necessarily licensure applicants, but in terms of the hiring world, there are not a lot of applicants applying to things. Just it would be hard to mandate that when there's nothing to help with that. Thank you.
Member Hall?
For Hall.
Mhm.
Talks a lot about, the administrative burden on pharmacists and the box checking. So I think that's something that we're striving to try to improve upon. It's a lot about mental health and, that, so I think we need to keep that in mind. Union is a big one for me. Better trained technicians we have and the more, abilities that we let them do. It frees the pharmacists up to do the clinical thinking that we went to school to do. Instead of, 50% of our work, helping do technician work. Just making pharmacy a good career choice, pharmacists and technicians, and awareness out there.
Member Goodman?
Board Member Biberman, well, those were big things. All those things were. So I would like to see the survey again. That would be a great starting point for how we think we're doing in that area. Being said it's 2 years old, I love that. I personally love the duty to report, so that Board of Pharmacy knows, what to work on. And I love the mental health concept, and I don't think that was included in the survey. Maybe it was, but I think we need to incorporate that. It wasn't in any of the in there at all. And that is a big, not, and I don't want to say topic because it's not a topic, but it's a problem. And it's a problem not just in Oregon, but it's a problem across America. And I think we should add that into our survey, into our rules if we can, and have a look at that. So that's what I have.
Thank you, Board Member Doyle. At a 30,000-foot level, if you will, I think about the new rules that are going to be fully implemented for pharmacy and technicians on March 1st. And then I think pie in the sky process, so to speak, would be considered, or that we would reconvene a work group, whether it be similar or different constituents of that work group through May and June, that would potentially create some rule revision discussion at the August and October board meetings, and potentially some opportunity to put forward to the public some possible rule adjustments in November of 2024.
Board Member Chin, thanks for the slide presentation. Know that the survey went out in 2022. Some of the changes we made didn't happen until 2023. And I know that another survey would be a great idea, but you just as noted by President Doyle, changes are coming March 1st. So I'm just trying to anticipate when you all think good timing another survey should take place in relation to the afterthought that President Doyle just said about convening a work group after the survey's gone out. So I would just try to keep in mind when that should go out. I do think it should go out.
Yeah, Board Joyce, I echo that sentiment as far as the survey and the timing of another survey. What stood out to me in the presentation was how many states were looking at quotas and metrics, and trying to keep that in check. That is a high stress point for a lot of outpatient pharmacies, having to meet certain metrics. And it looks like some states have touched upon that. Some of the things that stood out to me were the retaliation against the pharmacist retaliation or against their coworkers and so forth. The 72-hour requirement was interesting. I don't know if that's something we need to set in the rule. The work break requirements were, Oregon is actually pretty good at, I feel Oregon's doing a good job. I know that when pharmacies close for lunch, they make it known. They leave it on the voicemail, or they'll have a sign at the door that their lunch is this from 12:30 to 1 or whatever. The e-prescribing thing is interesting to me. Tech access, as board member Beeman had brought up, I think we should look at that to see if a technician could potentially open up a pharmacy or close a pharmacy, but without the pharmacist being physically present, but still being under this supervision and control of a pharmacist. Increasing technician tasks and roles to allow pharmacists to be able to practice at the top of their profession. I support that, ideas that look into that. And tech education, we need to have the technicians. I'm looking at wanting them to be nationally certified by 2028 going forward. It's just, we need to have the technicians going into their jobs with some education, with an education, a formal education, a certification. And then lastly, actually two more things. I think we should leave it to the outlets for any kind of tech to pharmacist ratios. And I think maybe we should put that in the rule that we recommend outlets have a official technician ratio, pharmacist ratio. And then we need to also look at issues that affect DEI. Thank you.
Member DeBarmore. Ben, when I had all those conversations before. The position has been explained, most of the years I've been on the board is, the board is neutral on, legislative items. The board doesn't put forth legislation, unless it's, operations or agency specific. I think the reason, and I don't know, probably wasn't part of the deep dive into what's happening in other states as far as electronic prescriptions are concerned, but I imagine the reason so many other states have that is because boards have put forth legislation. And that's why it's legislatively mandated. Washington Commission is actively putting forth that information that way. We haven't done that. That has not, and I don't know if that's the state position. That would be something. There are some areas within our statutes that need some finessing. And if it's not, the board directly, we need to speak louder so the association representatives that are sitting and listening understand and see the biggest issue for retail pharmacists, for outpatient pharmacists, aren't PBMs right at the moment, it's electronic prescribing. That will make their life better. Well, PBMs have an impact, I understand, but that has been for multiple years a big issue. We can't impact that from the board seat. Those are the things. Done a lot. We've done a lot. Thank you for that presentation.
It's been hard and painful, and I know we've upset a lot of apple carts, but been a lot of good things. So we need to now let it sit for a while. I don't know another survey is gonna make a difference right now. I think we've created some chaos, and it needs some time. People to understand what the impact is. A lot of it is good.
Board Member Patel, yeah, most of the topics I covered, so only going to include which is not usually covered in this discussion, so yes, we all know the staffing shortage, patient safety issues, pharmacy closure, walkouts, everything, we all know that bottom, that is the PBM issue, that's the another biggest issue. And I know we cannot do anything at the legislative level, but historically, I understand that, but I would definitely ask to look at the states such as Tennessee and Georgia. And there are a few other states, they are implementing action at the board level, at the board of pharmacy level to regulating the PBM. So that's the new thing we can look at what they are doing, and if we can do it at the pharmacy, board of pharmacy level. Other thing is like we have to involve more associations. That's another thing we can do. Instead of just the work group. More pharmacy schools, just more involvement with stakeholders. That's what I believe. And more deregulation.
Member Hemmings, I wasn't here when the original survey was done, but I would agree with Member Joyce, I think it was, that mentioned, employee wellness and DEI, which I think came up in our strategic plan. And I think if there's a way to incorporate that in any new survey that's going to be done would be great. I was just thinking about the budget. Surveys cost money. So in terms of timing, I wasn't sure whether or not that was already allocated in this current budget, so that would also play a role into when a survey would be done. I do agree with Board Member Lehman that a lot has happened in the world as well as in the field of pharmacy and individual lives since your last survey. There has been a lot of rules, some I understand have not yet taken effect, but things move very quickly. And I think based on budgetary issues, considerations, another survey is probably a good idea. Okay.
Board members for your attention and feedback. We have had 5 members at least indicating that a survey would be appropriate at this time, but we'll continue the conversation with staff on how we amalgamate this feedback. Board Member Beeman.
Member Beeman, Board Member Hemmings brought up an interesting point. Is the survey costly enough that it would prohibit a survey, let's say within this calendar year? And that we could repeat potentially 1 year from the last survey, like if we did 2 years in a row, because of changes that have already happened, and then as we know, there's changes that are going to happen, to kind of gauge how the changes that are coming into effect now have really, if they've made an impact and where, like, is it something that is cost prohibitive that we could potentially in this phase of everything do one this year and one next year, or is it at least in every 2 years kind of a budgeting thing?
Staff Member Davis, we have a subscription to the survey tool that we already pay for. It's just the time and effort to develop the new survey, send it out. collate the data, have meaningful conversation. But there's not like an additional cost to the board for sending out a new survey because it's part of our just annual subscription.
And I think I remember being, I think I kind of phrased that for like, in terms of costs, just in terms of labor resources for staff and stuff like that. Just a thought of, yes, it's kind of soon to see the changes, and we don't know the changes that are going into effect, but a lot of changes has happened that maybe a more frequent survey could be discussed or assessed in this era we're in right now. Thinking.
Hey, Executive Director Fox, we hear the will of the board of our survey, and that's something that we'll have conversations with the governor's office, once the budget kickoff this year and figure out as our planning for the agency, whether an annual or a 2-year survey. We'll add that on the list of things that we're going to discuss.
Appreciate that. Thank you, Director Fox, for putting that on the list. I was kind of wondering, I know this is safe practice, how hard it would be if it was an option, if anybody's thought about it, just to put that survey on when pharmacists and technicians renew their life. You know, asking questions about how safe they feel. I feel that as a technician, that perhaps if it was just for the technician, that they might feel more comfortable answering some questions rather than it going to everybody and being about everyone. Just a thought, especially considering, you know, the mental wellness of and their wealth of pharmacy personnel, and that you know, there's 8,000+ technicians in Oregon, or Oregon license, excuse me. But I thought that was a good idea. They brought that up at the NABP meeting that I went to, and I was on a task force, and they thought that was a good idea. I thought that I'd bring that back to my board.
Member Doyle, thank you for the recommendation. We'll transition now to a presentation from Board Member Patel. She had attended the NABP member forum, and it's her report from that. We have allotted 20 minutes for her report. Because of other business that we have to attend to, we may not have time directly after her presentation to have any conversation. Potentially that could be included as we in your comments as we move into matters to be discussed by the board. Member Patel.
Guys. Alright, timer. Okay, yeah. Alright, I try my best to remember and fit 1.5 day meeting in 20 minutes. During the NABP member forum in November 2023, we members brainstorm and exchange idea on diverse topics and how different states breaking barriers and resolving current issue and what regulation and legislation placed in their home state. So it sounds like a little bit come from, you know, Board Member Patel's brain, but that's not the case. You know, don't kill the messenger. All right, NABP Verify and Boards of Pharmacy. So NABP Verify program is designed to assist regulatory boards in monitoring and regulating pharmacists and pharmacists, particularly those practicing across state line. It provides ongoing verification that participating pharmacists maintain active licenses in good standing, helping reduce administrative burdens for regulatory boards. However, NABP Verified is not an authorization to practice pharmacy, but serve as evidence of licensures in good standing. It complements state statutes and regulation, offering additional oversight for non-resident practice models, but it does not replace traditional state licensure for in-person practice, which remains under the discretion of individual pharmacy boards. So benefits of the NABP Verify for the boards reduce the administrative burden on the board staff to verify license status, provides a system for continuous monitoring of license status across all states, provides member boards insight and oversight on the interstate practitioners. Currently, and that was last I checked in November 2023, that North Carolina is the only state accepting NABP Verify. Second topic was all about shared services, automated pharmacy systems, remote dispensing site, and tele-pharmacy. Discussion aimed to guide the development of a new pharmacy practice model, emphasizing meaningful pharmacist-patient interaction through expanded use of shared pharmacy services. We discussed highlighted the need for more flexible regulatory language to support innovation, criticizing current restrictive regulation that impaired the evaluation of pharmacy practice to address the public health needs. The consensus was that regulation should ensure public health protection while fostering innovation and eliminating unnecessary details and excessive requirement. Member praise for initiative undertaken by Canadian province and the state pharmacy boards, acknowledging their modification to rules and regulation. These changes allow pharmacists and the pharmacy technician to utilize their comprehensive education and training in delivering the patient care services. Boards achieve this by granting authorization for activities such as the pharmacist prescriptive authority and the pharmacy technician product verification. For the Canada, this is something new. I didn't know, but I think it's really good to share with you guys. So in Canada, pharmacy assistants and pharmacy technician differ in their roles and responsibility. So pharmacy assistant provide administrative and the customer service support with the tasks like inventory organization and customer inquiries working under pharmacist supervision. In contrast, pharmacy technician undergoes specific training, handle more complex responsibilities such as medication preparation, prescription processing, may interact with the healthcare professional and patients to gather information and provide medication-related instruction. Technicians work more closely with pharmacists, contributing to accurate dispensing and adherence to safety protocol with the qualification but with qualification verifying based on their jurisdiction and the healthcare setting. Pharmacy technician, they require certification or licensure, whereas the clerk may not require specific certification or licensure. So that's something new. Due over existing, and then they ask us to do the brainstorm. So each board member, and then we had to think about do over existing regulation pose obstacles to implementing shared services, automated pharmacy system, remote dispensing site, or telepharmacy. Should we consider deregulating current rules related to these technologies so simultaneously uphold the public health protection, encourage innovation, and eliminate unnecessary and burdensome details? So the one of the barrier I can think of or give the example is like we talked earlier about the pharmacy applicability, and the other rules is like, our prescription locker rule, which is division 143.855, 143.0210. So just for the example, ensure that stocking and destocking of prescription and non-prescription drugs, devices, and related supplies in PPL is completed under supervision, direction, and control of pharmacist, and ensure that Oregon licensed pharmacist verifies and documents that. So keep it, and all prescription and non-prescription drug, device, and related supplies were correctly stocked into PPL. Keep in mind that pharmacy prescription lockers are essential as expanded version of the will call system. According to this rule, it appears that pharmacists are required to continuously oversee and document each instance where technician placed prescription in the will call area. This seems impractical, excessively burdensome, which I already talked to other stakeholders, and that was we only have 1 or 2 PPL in the Oregon. Correct me if I'm wrong later. Drug shortage and compounding and USP revision. So USP update, I think it's the same slide. So drug shortages. So the supply chain is a long and complex and involves the numerous players, including raw material producer, manufacturers, wholesalers, distributors, transporter vendors, and among others. So retail pharmacy, they are facing shortage of the prescribed drugs. Like right now, currently is the Ozempic and the stimulants. Those are the two mostly that we discussed in that meeting. The shortages pose risk for the patient's safety, increasing the potential for the medication errors and driving some individual to seek medication from the questionable sources. The artificial shortages are also prevalent, especially for the stimulant. We discussed that primarily wholesalers, they determine the allocation quotas based on the ratio of controlled to non-controlled substances that filled at your pharmacy. So for instance, if your patient population primarily filled non-controlled substance through a mail order service and only filled controlled substance at your pharmacy, this may disrupt the controlled substance versus non-controlled substance ratio and leading to the primary wholesaler to restrict your access to the controlled substances. Similarly, that if your nearby pharmacy closed and causing an increase in your baseline volume for controlled substance prescription, this change can raise concern and potentially prompting the wholesaler to limit your access to controlled substances. We also talked about the Ozempic, compounding Ozempic. It was the hot topic that time. So on May 31st, 2023, the FDA, the FDA issued a statement causing against the use of the compounded semaglutide salts. Novo Nordisk, the manufacturer of the Ozempic and Wegovy, has clarified that it does not supply active ingredient semaglutide for compounding purposes. Despite this, some compounding pharmacies seems to be sourcing semaglutide-based active pharmaceutical ingredient from the FDA-registered facilities as required by FDA, so Food, Drug, and Cosmetic Act. The Alliance for Pharmacy Compounding, APC, suggests that Novo Nordisk patent pertains to be a finished drug product and the company produced semaglutide API, active pharmaceutical ingredient, from the FDA registered manufacturers. So as a result, APC take the position that this has allowed compounding pharmacy to obtain semaglutide base from the specific FDA registered facility, including a potential gap in control by the Novo Nordisk. So then we talk about like action by the Board of Pharmacy. So several state Board of Pharmacy, including Kentucky, Mississippi, North Carolina, West Virginia, have responded to the concern related to compounded semaglutide. They have issued position statement explicitly prohibiting the use of semaglutide salt, non-pharmaceutical grade semaglutide, active pharmaceutical ingredients such as the research chemical grade, and obtaining semaglutide from non-FDA registered establishment by compounding pharmacy. So not sure what our action plan is. To me, this is more concerning and affecting public safety than, I don't know, flavoring, compounding, whatnot. USP revisions. The United States Pharmacopoeia, yeah, that's the same. Okay. So United States Pharmacopoeia has finalized revision to its General Chapter 795 and 797 concerning pharmaceutical compounding of non-sterile and sterile preparation. This revision is official since November 1st, 2023, established standards applicable to both human and veterinary medicine. USP is not a regulatory body and does not enforce the standards. FDA and Joint Commission are regulatory bodies and can enforce the standards. And then reliance on the state licensing board. So we are just talking about that. The final guidance explained that FDA will rely on compounding pharmacists' home state licensing board to provide day-to-day oversight of routine compounding practices, but that FDA may provide concurrent oversight of compounding practices when considered appropriate. Should FDA have cause for concern, the agency indicated it may also refer the matter to the appropriate state licensing board. I'm not aware of any state that have fully embraced the either USP 795 or USP 797. It is possible that certain states have incorporated element of the USP standards, but not in their entirety, and certainly not with more stringent requirement that those outlined by the USP. That was November 2023. So I don't know what's the current situation now. Then AI application, how can pharmacy regulators can ensure the patient safety, pharmacist well-being? In pharmacy, artificial intelligence or AI holds the potential to automate the routine tasks such as ordering, verifying, dispensing, administering medication, providing valuable support to pharmacists and clinicians. However, concern about misinformation and and its consequences have led to emergence of responsible AI governance, emphasizing fairness, transparency, privacy, human safety, and explainability. Then they also talk about how do we incorporate that AI, artificial intelligence, in our board. There's a couple options. You can choose one of the publicly available AI and build interaction from your system to it. And the other one is like, you can install them within the board's network. I'm not the expert in the information technology. If you ask my sister, they think I'm a computer illiterate. So I'm not going to explain. You can, if you want to know more, you can find on the Innovation Magazine by NABP. Now this next one is the next slide. So driving supply chain security under DSCSA with the pulse by NABP. So DSCSA, that's the Drug Supply Chain Security Act, was signed into law in 2013. Over a decade ago, the US pharmacy profession faced a severe public health crisis involving contaminated injectable drugs from the New England Compounding Center, leading to a widespread fungal meningitis outbreak with 750 infections and 64 deaths. In response, lawmakers in Congress passed the Drug Quality and Security Act. The complex law divided into two parts. Title I, known as the Compounding Quality Act, gave Food and Drug Administration more authority to regulate and monitor compounded drugs that are shipped across the state line. Title II, the Drug Supply Chain Security Act, established requirement for the tracing of prescription drug products throughout the supply chain. The comprehensive implementation of the Drug Supply Chain Security Act demands that entire pharmaceutical supply chain achieve interoperability through a secure electronic methods to track each medication at package level. This poses a significant challenge for trading partners at all supply chain levels. Recognizing this, NABP has collaborated closely with its member boards and other stakeholders to assess the strategy for meeting this stringent requirement. NABP has developed Pulse by NABP. Pulse is inclusive, accessible, and secure digital platform that simplify the process of achieving DSCSA compliance. Pulse provides the regulators and trading partner with features specifically crafted to enhance and simplify their investigative efforts. Using platform, regulators can simply connect and initiate trace requests with all supply chain members, thereby expediting the investigation into the suspicious activities. The FDA announced that it would delay enforcement of certain provision of the DSCSA until November 27, 2024. And then more information you can file on the NABP website. MPJ issue, next slide. So the proposed uniform pharmacy jurisprudence examination, if adopted by states, would replace the state-specific multi-state pharmacy jurisprudence examination for licensee candidates. The UPJE aims to allow pharmacists in adopting states to demonstrate competency by taking a single pharmacy jurisprudence exam, meeting the law examination requirement across all recognizing states, and would be eligible to practice without the need for additional law exams. For the NAPLAX testing exams, this is more kind for the board staff. If you receive any complaint regarding this testing option, location, and limited time slots, please contact NABP or the Pearson VUE to address, and they will resolve this issue. The goal is to eliminate the barriers and ensure that more student pharmacists can enter the workforce as soon as possible. Then we also talk about marijuana and psychedelic mushroom regulation, but due to time, I would skip that one. The next one, yes, this is a great idea. Pharmacy working condition and pharmacy personal well-being. I'm pretty sure these issues are not unknown to us. The issue is not a recent development or a new problem. However, the COVID-19 pandemic, as anticipated, brought heightened attention to well-being and workplace issue within the field of pharmacy. Ensuring the safety of workplace condition for both staff and patients stands as the primary focus for NABP. Employees facing excessive workloads are at the high risk for the making errors, including medication mistake with potential life-altering consequences. In response to this concern, Lenora Newsom, the newly elected NABP president, declared in May that her presidential initiative will concentrate on furnishing tangible resources to promote mental health and well-being for pharmacists and the pharmacy staff. So we always focus on public safety. Now they're saying like we have to focus on the pharmacist and pharmacy personnel. There is really nice video on the NABP website. It's worth watching it. The well-being index score, then we also talk about well-being index score. So well-being index score equals 2 or greater than 5 indicate the risk of high distress, which is associated with a high likelihood of low quality of life, burnout, fatigue, job dissatisfaction, and the elevated risk for the medication errors. So I checked about the Oregon. So in November 2023, the distress percentage was 35.56%, suggesting that individual at risk for experiencing high distress. Notably, almost 1/3 of those facing high distress also exhibit a twofold higher risk for medication errors. In November 23, the Oregon ranked 17th out of 52 states in terms of the distress percentage. And interestingly, the Oregon state distress percentage rank in April 2020, about 3 years ago, was 37th out of 52. So the closer to 1 is more distress percentage, and closer to 52, that means less. So pharmacy professionals faced challenges due to the high-end workload brought by the COVID-19 encompassing tasks like administering vaccination test, COVID-19 test. Additionally, they grappled with the high employee turnover rates, harassment from the patient, diminished the resources, and inability to expand successful pilot project due to the complexity of the state pharmacy laws and regulation. We also acknowledge an agreement that there is not a shortage of pharmacists, but rather a shortage of desirable practicing settings, especially in the rural area. And unfortunately, these are problems in every setting, just not the retail. Leads to significantly decreased enrollment in the pharmacy school. Enrollment in pharmacy school has markedly declined, and yet the demand of pharmacists has risen. If these trends persist, there may be an insufficient number of pharmacists to address the healthcare needs, particularly in rural area. So they're asking the members that school involve your school and college of pharmacy. We have to actively engage in conversation to enhance the image of community pharmacy practice. Don't worry, guys, you can do it. In addressing pharmacy staffing concern, there was an exchange of idea of collaborative use of the pharmacy technician to complement the role of the pharmacist, emphasizing boards of pharmacy to reassess and potentially amend regulation, allowing pharmacy technician to take an expanded responsibility for professional development. Example, including accepting new phone in prescriptions, verifying filled prescription, and administering vaccination. Additionally, a review of the regulations specifying tasks solely for pharmacists to determine if non-pharmacist personnel can safely and competently perform them, with the corresponding revision it's applicable. Now, encourage Board of Pharmacy to explore innovative pathways, including automation, central fill system, to revitalize delivery models that empower pharmacists to offer patients care services and tackle staffing shortages. At that point, it's like if you have constantly shortage of the staff, what can we do? And the answer is innovation, more automation. We deliberate the financial and regulatory challenges that commonly hinder pharmacists from implementing technologies advancement to ease workload pressures. Recognizing that investing in a new technology might not be justifiable if limited to few states, emphasizing the importance of addressing such barriers. PBM issue. So NABP, they acknowledge an agreement that existing work condition in pharmacies, including closures, walkouts, staffing challenges, and decline in enrollment in pharmacy schools are interconnected with the low reimbursement rates and problems associated with the pharmacy benefit managers. While historically, they viewed as a business decision. Now this issue have now emerged as a significant factors affecting access to care. While in agreement that the boards of pharmacy often face limitation in directly addressing this issue as it required legislative intervention, there were discussion on the initiative boards of pharmacy are currently undertaking at the state level regarding the PPM regulation. And those are the states are the Tennessee and Georgia, and there are a few others.
Member Patel?
Yep.
I need to interrupt you at this time. I had you start at 3:31, and we have some other business that we need to get done. So I would invite you to complete your presentation after we get that other work done, or finishing up at the next meeting.
No, I just want to read 2 minutes, how about 2 minutes? And I'm done.
Okay,
All right. I just want to read this following, and that didn't come from me. So the task force also consider regulatory barriers that may contribute to pharmacy personnel stress level without adding commensurate public health benefit. They suggested comparing mental health issue in state with the higher versus lower regulatory barriers. It was noted that many states relaxed their regulation during the COVID-19 pandemic, and reports of patient harm have not emerged. Members observe that strict regulation do not necessarily benefit public health. That's it. There's more, but oh well.
thank you very much. You're welcome to request more time at the next board meeting if you'd like to finish up with those other comments. Board Executive Director Fox, you have a report on legislative update, please.
Hey, Board President Doyle, the 35-day legislative short session started this past Monday, February 5th. Agency staff and I, we testified before the Senate Committee on Healthcare regarding an overview of the Board of Pharmacy. We provided the board materials via email, and we also uploaded the testimony to our website under the Contact Us tab. Operations Manager Melvin has reviewed all 500 bills that were filed, and any bill that had pharmacy stated within. We're monitoring about 17 specific bills that may have an impact on the board, and we provided feedback to various committees in the legislature regarding technical language changes as we've seen so far. Yesterday, provided to the board, the state enterprise economic and revenue forecast that was released on the 7th. The legislature came into session with about $1.7 billion to spend due to the combination of dollars left unspent at the last session, increase in revenue forecast between then and December, which nearly all those funds were accounted for. There are about $2.2 billion of requests for new programming needs, and very few requests will likely be filled. Majority of those funds will go towards the governor's priorities around housing, education, behavioral health, and addiction treatments. Agency staff is in discussion with the governor's office and the CFO regarding agency legislative funding and resource needs for the 25-27 biennial budget period. Some of those items we are planning for the next budget period are some staffing resources and realignments. One specifically for a deputy director for the agency, and some other reclassifications of current positions identified by CHRO-HR. Some language service support, board and agency staff training resources, DEIB training resources, some IT infrastructure revisions, continuing education support, potential fee increases to cover licensing and registration fees, and the policy packages that's being discussed, evaluation of what's equitable and defensible with those possible fee increases, with those applications, and necessary to maintain the current level of service and balance annual cost increases. The other policy areas are increasing support for administrative hearing requests. Increase in hearings over the last few years have increased. And to assist with the basic inflation cost does not cover those costs that increased over years. The HPSP legislative concept and database maintenance support. And overall, we have about 2 legislative concepts and 7 policy package overall. And the enterprise-wide budget kickoff meeting with the governor's office, CFO, and agency staff is mid-March. It includes the presentation, President Doyle.
Thank you very much, Executive Director Fox. We now turn to setting board meeting dates for the future, and we need to take action on those. There will be a special virtual meeting of the board this upcoming February 23rd, 2024 at 10:30 a.m. Please see our board meeting agenda on our website with respect to that meeting. It's anticipated to be a very short meeting for some cleanup things, so to speak. We have before you the Jennifer or Melvin, were you to talk about the dates, or should I do that? Okay. You have before you the meeting dates on the public agenda. On the public agenda, there are the meeting dates for 2024 that are planned, including mid-April, June, August, October, etc. And we will now discuss proposed board meeting dates for 2025 with Executive Director Fox.
The proposed 2025 board meeting dates for 2025 is outlined in the agenda. February, April, June, August, October, and December, and the dates outlined. President Doyle, I will look to you and the board if it's the will of the board to agree on these dates, or if there's other dates that you want staff to look at.
Board Member Doyle, thank you, Executive Director Fox. These dates seem to be aligned with similar timeframes that we have been using for the last few years. Is there any board discussion with any difficulties with these dates that are being proposed for the board?
So November is gonna be a I'm gonna retire, so. Oh, you're gonna retire.
Board Member Doyle, that the November 5-6 is strategic planning, and that can be potentially amended in the future.
This board member Joyce, do we have a location in mind for that?
I believe that is still to be determined.
Or should we suggest locations?
Not at this time. We'll have plenty of time to plan for November of 2025. Yeah. Is there a motion to approve the 2025 board meeting dates as proposed?
Cindy Bipperman, board member, I motion that.
For a second.
Board Member DeBarmore seconds that.
I will call a vote. Board President Doyle, yes.
Member Chin, yes. Member Beeman, yes.
Member DeBarmore, yes. Member Hall, yeah.
Member Herman, yes.
Barbara Joyce, yes.
Board Member Patel, yes.
Board Member Viverman, yes.
Motion passes for the 2025 dates. Is notable that we have some upcoming, we have set the 2024 rulemaking hearing dates. Those are February 22nd, May 22nd, and November 26th. We now need to approve our consent agenda. Is there any board discussion with regard to our consent agenda, handout consent 1 and handout consent 2? Licensure, ratification and board meeting summary, respectively. Hearing and seeing none, is there a motion to approve the consent agenda as proposed? Is
Member DeBarmore, so moved.
there a second?
Shin, second.
I will call the vote. Board Member Doyle, yes.
Member Chin, yes.
Member Beaman, yes.
Member DeBarmore, yes. Member Hall, yes.
Member Herman, yes.
Barbara Joyce, yes.
Member Patel, yes.
Board Member Viverman, yes.
Motion passes. We now move to public comment. May I please invite Brian Mayo from OSPA to the microphone? We will now take public comment. Please note that the board will not deliberate items such as formal requests, issues currently under investigation, requests pending before the board, or currently proposed rules during public comment. Each person has 3 minutes to speak. Mr. Mayor, you have the mic.
Thank you. Good to see everyone again. Just want to, there's 3 topics I want to cover. First of all, thank you to the board members for appealing the rule that pharmacists must not diagnose. We appreciate the work over the past few months to get this rule fixed to help pharmacists and patients across Oregon. So thanks for finalizing everything. Since I do have 3 minutes, my second topic is that we want to let you know that OSPA is very concerned about the opioid epidemic, and we want pharmacists to be part of the solution here in Oregon. Oregon is currently ranked 2nd in the nation for deaths due to overdoses and last in the nation for the number of treatment facilities. Multnomah County has declared a state of emergency due to the fentanyl crisis. Ensuring equitable and timely access to life-saving treatment options will be paramount in addressing this crisis and maintaining patient successes. Just like how pharmacists led the charge to get shots in the arms during the COVID pandemic, pharmacists have a unique opportunity to aid in the opioid treatment effort. Legislation passed in 2022 eliminated a federal barrier to pharmacists prescribing buprenorphine. So far, 11 other states have taken action to allow pharmacists to apply for a DEA license. This afternoon, I met with the PFAC, whatever you want to call them, the chair, Lorinda Anderson, and others to discuss what Oregon pharmacists can do to help. We will be working with the PFAC to propose a protocol to allow pharmacists to manage buprenorphine and buprenorphine naloxone therapy. So keep an eye out for this in the future. As far as legislation goes, we are facing a critical situation with pharmacy closures and patient access. Oregon had 36 pharmacies close in 2023, and there were 2 more that closed last month. Due to the closures and increased workload at open pharmacies, at this point, every pharmacy in Oregon should be considered a critical access pharmacy. We currently have House Bill 4149 working its way through the legislative session, which addresses PBM reform. I'd like to encourage all the board members, staff, and pharmacists who are listening to this call to contact their legislators and encourage them to vote yes on the PBM bill. This is not the same bill as what we had in 2023, but includes some good pieces of legislation that will set the foundation for the long session in 2025. Thank you. Thank you.
Thank you, Mr. Mayo and OSPA. That concludes the person signed up for providing public comment at today's board meeting. We will now transition to matters to be discussed by the board. Before we adjourn, the board members, so that's a later announcement. I apologize. So we invite each board member to provide comments, ideas, items for future board meetings, or things that had promulgated thoughts at the meeting for these last 3 days. We had left the round robin also with board member Bd Mtg, and so we'll begin with board member Hall.
I should have prepared more for this. The thing that's at the forefront of my mind that affects me every day at work right now is, refrigerators and freezers going out of range for 1 second and the amount of work that it's taking. So I would like us to talk about that at some point.
Member Liverman.
Board Member Viverman, as always, I would want to, not that I have a say anymore, but I would like to just make a plea for the board to continue to discuss technician education for public safety reasons, for all the reasons that I've stated for the last 8 years. I'm seriously sad that I'm leaving this board, and that is whatever we had, the NABP is, excuse me, the national certification, we don't require that anymore. Saddens me to know that what I was put here on the board is, did not happen. So I encourage the board to please look at technician education, national certification, something to educate our pharmacy technicians.
Thank you. For myself, board member Doyle, I don't have any comments to share with you today. Board member Chin.
Chin, just regarding the strategic plan in November 2025. It's on a Wednesday, Thursday, and last year we did it on a Thursday, Friday, so maybe a consideration Thursday, Friday.
Member Joyce.
Board Member Joyce, I just want to recognize Cindy Viverman for her 8 years for the Cindy Patient Safety Government. You rock. So I'm happy with what we reviewed today, especially the repeal of the diagnose in that section. I think that would have caused some unintended consequences with collaborative groups. Tech education, of course, is forefront for me, and I'm looking forward to further discussing drug compounding. What worries me the most is going to the potential for staffing or low understaffed pharmacies in the near future with the low enrollments in schools in the pharmacy schools. And so what are we going to do about it? It continues to decline. It's at basically 65% of what it was 10 years ago and continues to decline. So what are we going to do about that? The number of graduates is going to decrease. Are we going to look towards AI to help us out with that? So that's where I'm at. Thank you.
Board member DeBarmore.
Board member DeBarmore. I didn't get the things I wanted either, Ms. Wickerman. I encourage you to continue to evaluate technician scope and the things that technicians are allowed to do, such as being responsible and being able to open and prepare a pharmacy for a pharmacist prior to them being there, whether it's in an institution or in a retail pharmacy. So I continue to plead and beg, just open your minds to the thoughts that we do have responsible technicians out there who do a lot of good things. Secondly, coming across some things recently that have really opened my eyes. We are the responsible parties for drug safety in this state, and there's drugs in a lot more places than within the walls of a pharmacy. There's drugs being compounded and used in areas, that are impacting patient safety, and under conditions that aren't necessarily, conditions that we would, expect, and we certainly hold our pharmacies to standards that are significantly higher. Just looking at refrigerators, we have drugs that are being injected into people's bodies who aren't being stored in conditions in places all across the state that aren't inside a pharmacy, that are not being held anywhere near the condition that our experts are being held to. So I ask that you keep that in mind as you're looking at areas to focus on. Focus on the drugs and the safety of the drugs.
Member Patel, yeah, I would definitely like to revisit those temperature rules while board member Deborah Moore is on the board. Otherwise, we need a clause that she can't leave. Yeah, but I would definitely like to revisit those temperature. And then we definitely have the one of the concern I have about the hydration clinic when I go to the NABP board member forum. Definitely we have to look into it. Because certain state they say like, I know I hear you that if it's come under the provider, then yeah, it's board of medicine or board of nursing, but then I know that there is a hydration clinic, they don't run or operate by the providers, then it should come under the board of pharmacy. So there is a North Carolina for reason, for example, I think they have pretty good rules for those hydration clinic. And that's really concerning for me. So we should look into it.
Superintendents, we had our strategic planning meeting in November. And I was just wondering when we're going to actually look at that. And in alignment with the governor's focus on equity, a lot of boards are actually reading developing an equity statement and reading it at the beginnings of their board meetings. And that's something I would like to recommend for this board. I don't think we currently have an equity statement. But that is a part of the governor's agenda. And board member Rickman, I wish you the best. And it was nice meeting you. And I will miss knowing exactly how you're going to vote. And I miss you and board member DeBar Moore. Going at it.
Member Bd.
Member Beeman, I also would like to publicly acknowledge Cindy, patient safety Riverman, as she is now known. You are an inspiration. You are a great example of passion and integrity and all the right things that board members should be and represent. So thank you for your service and thank you for your voice and all the hard work that goes into this. I am looking forward also to perhaps seeing and reviewing and reassessing the refrigeration rules and as well as the patient safety. I'm glad. Thank you for the presentation, even though it was a meeting delayed. Staff Member Davis, I think things are changing very quickly and we need to reassess certain aspects of the rules and of the practice a little bit faster and more frequently than we have in the past, in my past history on the board. So thank you.
Going on, thank you. Executive Director Fox, could you forecast the strategic plan and or equity statement? My memory is that we had made an elected decision for planning for this board meeting to defer that due to other competing agenda items and also the timeliness of other pieces of information that were coming in from other parts, that it was better to have April focused on that.
Thank you, President Doyle. So as it relates to our strategic plan, what agency staff is doing right now is working on a draft plan. So we want to thank you all for your feedback that you provided over the last couple weeks. So we're taking that, coalescing that, and we're going to bring that back in April. For this board meeting, as you can see, there's a lot of conversation, dialogue that needed to happen, and we wanted to make sure that we got through a lot of the rules and discussions you had today and package your next meeting up with your strategic plan. And then we're going to have, we're going to have a member of the governor's team from the appointments office come and talk to you about the governor's expectations and some other items from the governor's office, as well as part of the strategic plan. Part of the governor's expectations is developing a DEI-B plan for each agency. And so that's the expectation of the governor that staff is also working on right now. And we hope to at least have a draft that we can also bring forward to the board along with strategic plan in the April board meeting, with the goal of having all the plans as outlined by the governor completed, done, and to the governor's office by June. So June is our deadline.
Thank you very much for that off the cuff assistance. Staff member Davis, would you like to do anything?
You are the president of the board. I will let you decide. I could do a couple more rules or we can end. That is 100% the board decision.
Board member Doyle, I understood that it would be very important to finish that section that you were on.
Member Davis, it would be helpful. We still have 2 more rules in that one section. If we could finish those discussions, that would just be helpful. If not, we'll wait. All right,
Can you say mailing D?
Huh?
Mailing D?
This is going to be mailing D. We're going to just reopen. We were in 855 183-0200. We had finished discussing paren 5. Next, we're going to have a discussion on paren 6 and 7, and then we would conclude the board meeting if those conversations can go quickly. If not, we might just get paren 6 done, but we'll try. This next rule, paren 6, is beginning July 1, 2025. Again, this could be pushed out. This was the draft language from a while ago. A drug outlet that prepares CSPs from non-sterile ingredients must maintain current accreditation, and it lists 3 different accreditation options. The work group did provide consensus to implement this rule as written, as the risk of contamination is especially high when performing non-sterile to sterile compounding. Accreditation requires outlets to meet strict requirements and helps to ensure that the persons performing this type of compounding are doing so safely. So same discussion we've had before, may versus must. This was a higher recommendation from the committee about utilizing accreditation just for non-sterile to sterile compound. Back to you, President Doyle.
Member Doyle, thank you. We begin responses to your question with board member Vipperman.
Board member Vipperman. So the question is may or must?
Or not at all, I mean.
Or at all, okay.
You-
So this is rules that our experts agreed on.
This was the consensus of the work group for this very narrow type of compounding that's considered high risk.
I agree about that. I would like to say must, but circumstances when you're doing compounding are very different than when you're filling a prescription. So I would like to for all time say may.
Board member Doyle, my understanding is that they have choice, but amongst the 3 that are listed here, I think that they'll be able to choose the one that best fits, but I do agree with must, that they should be, having that certification. Board member Chin,
Remember, Chin agrees with must.
or, Joyce,
Former Joyce, I strongly agree with the recommendation of the board, or with the group, and that is must.
or DeBarmore.
Board member DeBarmore, I do understand this is a narrow area. It is a high risk area. I can understand making this a must. I would be interested to hear putting that language forward again for rulemaking, because it wouldn't be adopted, so for rulemaking with the must, but I would recommend a longer implementation, so I would say 2027, not 2025.
Member Patel.
Remember Patel. I don't remember that work group members say that must for those for those certification. I don't recall that. So it should be recommended, should be a best practice, but this is something new we are making in the rules. Should be a recommendation, not must. That didn't come from the work group members. It's just, again, give the options. Do you want, you don't want certification? So they pick one choice.
Member Evans,
Nothing to add.
member Beaman,
Remember, Beeman, I am in favor of May. And indicating that if we are going to put these rules in our rules, that this is the direction the board is heading, but not mandating it at this time.
member Hall,
Member Hall. I certainly wanted to say must, but if it was a must, I'd want to extend the 2027, like board member Bartmore mentioned. Me down for May right now.
member Doyle. It seems as if we have a divided cohort, between, may and must. Possible that, must could be implemented if, dating is extended to 2027. Member, sorry, staff member David.
Thank you very much.
Now, I'm so sorry, staff member Melvin, we need to pause for just a moment. Believe maybe our network went down. I need to see if our Teams meeting is still live. Give me just a moment, please.
Just a second.
Hold on just a second. Yes. Ready? Hold on just a second.
Testing. Testing.
Can you hear me, staff member Davis?
I can.
Did you hear me? Okay.
Reopening mailing D. Sorry for the technical issue for those that are still on Teams call. Maybe.
Yeah, we're done.
We just need to be done. We're having technical issues. We can't get the rules back up online.
Sorry about that.
Before we adjourn, for board members who took written notes during the before or during the board meeting, please provide your written notes to staff member Melvin. Please add your name and today's date and quote confidential end quote written upon them if they were taken during executive session. If you would like to keep your written notes, please go to the board office before you depart the building so staff can make copies. If you took electronic notes outside of OneDrive, email your notes to rachel.melvin@bop.oregon.gov. Is there a motion to move to adjourn the meeting at 4:30 p.m.?
I, board member Cindy Vipperman, move to adjourn.
Is there a second?
Member Chin seconds.
I'll call the vote. Board member Doyle, yes.
Member Chin, yes.
Member Beeman, yes.
Member DeBarmore, sadly, yes.
Member Hall, yes.
Member Hemmings, yes.
Member Joyce, yes.
Member Patel, yes.
And for the last time, board member Vipperman, yes.
Thing that you're last in the alphabet.
I know.
That's on end.
Only time I'm happy to be last.
Yeah. Motion passes. The February Board of Pharmacy meeting is closed.